So my task is to talk about diagnosis, risk stratification, and response assessment in AdvSM in 2026. And it's a lot to cover, so let's jump directly into the diagnostic criteria for systemic mastocytosis. As Andreas has already very nicely alluded to, we have a complex disease, we have a rare disease, it is very heterogeneous, so there are some diagnostic delays in patients with systemic mastocytosis. But once you consider diagnosis of systemic mastocytosis, there are two different frameworks that help us to diagnose SM. And these are the WHO classification and then the ICC classification, and both differentiate between one major and four minor criteria. The major criterion is the multifocal dense aggregates of mast cells, and the four minor criteria include an atypical morphology of mast cells, a phenotypic driver mutation KIT D816V or any other activating KIT mutation such as H, Y, N, and an aberrant expression of CD2, CD25, and or CD30 on mast cells, and tryptase levels of above 20. So most patients will likely undergo a bone marrow biopsy to be able to be diagnosed with SM, but formally this is also possible from any other extracutaneous tissue. Once we have diagnosed systemic mastocytosis, we need to subtype. That's the next step. Mast cell leukemia is diagnosed when 20% of mast cell, or when 20% of mast cells account for, or when mast cells account for 20% of the cells in a bone marrow aspirate. We then also should check for an associated hematologic neoplasm. This is diagnosed as SM-AHN when the diagnostic criteria for SM are fulfilled, but also for one accompanying hematologic neoplasm as per WHO or ICC classification. SM-AHN is the most heterogeneous and also the most common subtype of advanced systemic mastocytosis, and most AHNs are of myeloid origin and often resemble an CMML or an MDS-MPN overlap, and less commonly an MDS or chronic eosinophilic leukemia. Then aggressive systemic mastocytosis, ASM, is diagnosed when we have C findings, and these C findings are shown on the right side. They include different cytopenias and other signs of organ infiltration and organ damage, such as liver dysfunction with or without portal hypertension, palpable splenomegaly with hypersplenism, gastrointestinal infiltration with subsequent hypoalbuminia or malabsorption, or skeletal involvement with large osteolytic lesions. However, the last one is quite uncommon in comparison to the other ones. So aggressive systemic mastocytosis formally requires the presence of C findings. This is not the case for SM-AHN or MCL, but also those patients with these subtypes often do fulfill C findings. If we do not have C findings, we should check for B findings, B for borderline or burden of the disease, and if two or more B findings are present, the diagnosis is smoldering systemic mastocytosis, and if this is not the case, the diagnosis would then be indolent systemic mastocytosis, or if the mast cell burden is very limited to the bone, then we call this bone marrow biopsy as per WHO classification. So this was also already captured in Andreas' talk. We have different criteria, we have different parameters that we should assess, and we have to do this in an integrated assessment for the individual patient, because while all these framework and diagnostic criteria are very well established and they haven't changed a lot during the last couple of years, they do not capture the disease burden probably not in every patient very well, because they do not always correlate very well with each other. So we need to assess tryptase, we need to assess KIT D816V allele burden in peripheral blood and in the bone marrow aspirate. We need to check for additional somatic mutations. We need to do this bone marrow biopsy, assess for symptoms, because they each tell us a different part of the story in the individual patient. But now let's move on and let's jump from diagnostic criteria into the disease biology. And this is a very busy slide, and I would like to walk you through this slide. And it's really, what is shown here really nicely points out that mast cell and systemic mastocytosis, and especially advanced systemic mastocytosis, is not just a KIT D816V positive mast cell disorder, but in fact it is a multimutated stem cell disorder. And patients in this analysis, we analyzed 176 patients in the pooled Explorer and Pathfinder clinical studies. Their avapritinib was evaluated for efficacy and safety, and those patients underwent a 54-gene panel at baseline. And these analyses are now shown here. We see that over 94% of patients had at least one additional somatic mutations beyond this KIT D816V mutation, and the median number of additional mutations was 4 per patient. And they occurred in various combinations with each other, and most commonly we saw mutations in TET2 and SSF2. But what does it mean for prognosis? We also looked at that in different genes. And you can see that mutations in ZBP1, RUNX1, and SSF2 were associated with adverse prognosis in patients treated with avapritinib. We also checked for mutations in NRAS and DMT3A. They were previously reported in other reports to be associated with prognosis in broader SM populations, but we could not find any statistical significance here. For ASXL1, we know this is from historic cohorts. We know that also very well described over the last couple of years. We found here in borderline significance with impaired prognosis. But what does it mean? It really means that we should incorporate molecular profiling into a prognostic risk stratification in advanced systemic mastocytosis. Another important point when we talk about risk stratification is that we now have a completely different field of therapeutic, landscape than a few years ago. Cladribine is a purine analog that now has been used for over 2 decades. However, it is not formally approved for by FDA or EMA. Midostaurin is a multikinase KIT-including inhibitor, and avapritinib is a specific KIT D816V inhibitor, and both drugs are approved by FDA and EMA. And this different Kaplan-Meier comparison that were each done in statistically optimized settings really show that the prognosis has improved over the last couple of years. What does this now mean for risk stratification? What score should be used nowadays? There are several scores that had already been introduced into the landscape of advanced systemic mastocytosis before even the trials on avapritinib has started. So we have 4 different scores here, and the original mutation-adjusted risk score, the MARS, and the International Prognostic Scoring System for Mastocytosis, the AdvSM, are the only 2 scores that were built in an advanced SM-only patient population. However, these 2 scores, but also all 4 scores, do not really capture the current treatment landscape, and all of those parameters that were included in this score also are based on categorical variables and put the patient into different risk categories. And this led us to the development of the revised mutation-adjusted risk score, MAS-R, and you can see that this really captures the current treatment landscape with midostaurin and avapritinib being approved in advanced SM. And this score is now based on 8 variables, which were identified in a multivariable analysis. It includes higher age, higher monocyte count, and lower platelet count, as well as male sex, absence of skin involvement, and additional somatic mutations were associated with reduced overall survival in this analysis. And we put those continuous and categorical variables together into a continuous scoring system and also divided this into different risk categories. So the MAS-R now really captures the continuous overall survival risk in an individual patient and can report unique individual scores for a patient that was treated with avapritinib or midostaurin. And the MAS-R is directly interpretable because negative or positive scores reflect worse or better overall survival with the comparison with the average risk advanced SM patients. And what you can see on the right side is that this continuous modeling also not only differentiates the prognosis between different risk categories, between low risk, intermediate, and high risk, but also within one risk category. And MassR is now available as a free online tool. You can scan the QR code on the upper right side of the slide or enter www.mass-r.com in your web browser. And this helps you for a standardized application of the MassR to the score. What about validation? Validation of this score has successfully been done, and these results, I'm very happy that I can present these results tonight in the poster session. So you are very welcome to step by and can also discuss the score in more detail. But for now, let's move on from baseline risk stratification to the response assessment in advanced systemic mastocytosis. And one of the most important parameters is the KIT D816V allele burden. And the KIT D816V allele burden should be measured in peripheral blood and, when available, always also in the bone marrow aspirate, because we can identify multilineage involvement with it, but also measure molecular response and the residual disease burden in advanced systemic mastocytosis. And when doing so, we should also always think about highly sensitive methods such as digital PCR or qPCR. And this analysis shown here was picked from the updated Pathfinder analysis on, again, avapritinib, with now a median follow-up of 4 years. And you can see that 96% of patients were KIT D816V positive at baseline, and avapritinib rendered KIT D816V VAF to below 1% in 64% of all patients and in 67% of first-line treated patients, really showing how effective specific KIT D816V targeting can be, and also that serial measurements of KIT D816V can help us to measure the disease burden during the treatment course. What about more standardized response assessment? We have this modified IWG, MRT, and M criteria. As those criteria were developed for standardized response assessment in clinical trials that are looking at specific KIT D816V inhibitors. They introduced a standardized response categories with low risk, intermediate risk, with complete remission, with partial remission, with a stable disease or progressive disease. But they are quite complex because they really incorporate different dimensions of response with organ damage, with a mast cell burden in the bone marrow, tryptase levels, hematologic parameters, serum chemistry parameters, but they help us to more standardize, to measure the treatment benefit in a more standardized fashion. For the real world, for the routine practice, those criteria will be very challenging to just quickly implement it in the daily clinical routine. So we need more practical, complementary assessments. And we can use the PPR criteria for this. This was also really work done by Jason Gottlieb. And these PPR criteria really focus on tryptase levels, on bone marrow mast cell burden, on hematologic parameters, and KIT D816V. And these are way easier to implement in the daily clinical routine and also associated with prognosis. Even more simple is the measurement of KIT D816V and tryptase levels from the peripheral blood. These are parameters that are very easily available. And these parameters also allow us to really have a very quick and quick measurement of the treatment response, and they can serve as early biomarkers, as shown here in the different Kaplan-Meier curves. On the left side, you see that KIT D816V allele burden reductions of more than 10% as early as in day 15 in patients, again, treated with specific KIT inhibitors, can serve as a prognostic marker. And on the right side, you even see that we looked at something like halving time, and halving of tryptase within 30 days was also highly predictive and highly prognostic relevant in these patients. And they can help us to refine prognostic and baseline prognostic assessment in such a patient. What else? We also, of course, need to consider response. Besides response assessment of more or less objective biomarkers, we also need to ask our patients, how are they doing? And you can really see in this touchstone survey on 56 patients with SM the magnitude of disease burden in advanced systemic mastocytosis. So there are different pros available, and we should use them in our patients to also have a broader picture about the patient. So this brings me to the key learnings. Diagnosis and disease assessment require an integration of several parameters. For risk stratification, we have the MAS-R now available. We should use highly sensitive methods to detect and then also measure KIT-D816V during the disease course. For clinical trials, we have those standardized response criteria, which are challenging to implement in the daily clinical routine, but can be substituted by other parameters. And of course, we need to use the patient-reported outcomes to measure the symptom burden in our patients.